All right, good morning. We'll go ahead and get started. So this morning I'm very happy since it's a lung-centric topic, so we have a really important grand rounds by one of our pulmonary critical care folks at the Oregon Clinic, one of the new faculty, Dr. Rick Balestra. So Dr. Balestra was born in Buenos Aires, Argentina, where he did his medical school at the University of Buenos Aires. He then did internal medicine residency at Albert Einstein, where he also served as chief resident. Then he did fellowship at Stanford University, and after fellowship pursued a separate fellowship in interventional pulmonology at the University of Cincinnati, where he helped develop the lung cryobiopsy program, which I've seen once and want no part of, but I'm sure he'll talk about. He eventually ran out of ideas for other fellowships to do, so he then joined the Oregon Clinic in 2017, where he is full service, does inpatient, outpatient, and also helping to expand their interventional pulmonary program. So, Dr. Balestra.
All right. Good morning, everybody. Welcome. I wanted to talk a little bit about advanced bronchology, interventional pulmonology, and a little bit about what I do and some of the things that are available currently here at PPMC, and then some of the stuff that we're hoping to get to PPMC to start offering. So I have no disclosures. We always have to come up with some learning objectives, so if you can name two of the things that I say today, that's a win. But essentially, I would like you guys to kind of familiarize yourselves with the some of the techniques, diagnostic and therapeutic techniques that are available here, and then identify suitable candidates for bronchoscopic biopsy. I think it's something important that you might encounter frequently in your practice, and so I feel like that's probably an important thing to learn. And then I want to put in a shout out to bronchial thermoplasty, which is a newer treatment that we hope to start providing here in the next month or so. So I think it's cool to get you knowing about that. So what are the interventional pulmonology techniques available, or at least that exist? So broadly categorized into diagnostic and therapeutic. So diagnostic ones are the most common ones that we do and that you see. That includes EBUS, which means endobronchial ultrasound, and all the biopsies you can do by endobronchial ultrasound. So that's what's called EBUS, transbronchial needle aspiration. Navigational lung biopsies. I'm going to talk a little bit about bronchial genomic classification analysis, which is testing for gene mutations in the airways to assess nodules. And then I'll talk a little bit about cryobiopsies. And then the therapeutic techniques include rigid bronchoscopy. Through a rigid bronchoscope, oftentimes we deliver hot therapies like lasers or argon plasma coagulation. We can do stents. There's a cryospray that we have available that's also a treatment that we can use for lesions, for bleeding or masses. Photodynamic therapy, bronchial thermoplasty, and endobronchial valves. So these are the things that are mostly available currently at UC. The only thing that we don't have yet is cryobiopsies. So I'll start with a case. This is a 68-year-old female. She was a former 10-pack year smoker, and she had incidental lymphadenopathy on imaging that was done for cough. And you see that she has bilateral hilar and subcarinal lymphadenopathy, and there was FDG avid on a PET scan. So here's one case. Another case is a 53-year-old male who had a previous pneumonectomy for lung cancer, and you see the left lung is missing. And on surveillance, he's found to have an FDG avid lesion. He's got adenopathy both in the paratracheal area and subcarinal, so you can see these lesions. So for both of these cases, I'm trying to kind of exemplify what the approach would be diagnostically. So of all these interventions that are available, which one would you recommend, or which one would you use for diagnosing essentially this condition, which is mediastinal lymphadenopathy? So essentially, disease near the airway, surrounding the airway. So there's endobronchial ultrasound guided lymph node aspiration. You can do a cervical mediastinoscopy or a VATS approach. And there is no right or wrong answer for these. I'm going to try to convince you that endobronchial ultrasound, or EBUS, is the way to go. But all three would be ways in which you could get these lymph nodes. So what is endobronchial ultrasound, or EBUS? It's a scope that has an ultrasound in the tip and a needle that comes out at an angle. And so what this lets you do is it lets you see a lymph node and put a needle into it under direct visualization. So you know you're in the lymph node. It's very safe for that reason. And it allows you to get cells. You can aspirate cells, and you can also aspirate cores of tissue, depending on the size of the needle that you use. And so this is a really great technique for this type of thing. So there's all these lymph node stations, and we can access many of them with EBUS. You just go in with a scope and just look in different directions, and you can find all these stations and sample lesions in any of these positions. So the only requirement is that the lesions be adjacent to the airways at some point, so that you can get an interface and you can see it on the ultrasound. If there's something between your lesion and your airway, then you won't be able to see it and you can't do it. You're also limited by how far you can get the scope out into the lungs. So the scope, as the airways narrow, you can only get the scope out so far. So it typically works for paratracheal lesions, and then hilar up to the bilateral hilar areas. So essentially, the indications for EBUS is diagnosis of staging suspected lung cancer is probably the most common indication for it. Like these cases that we talked about that I showed you, diagnosing any mediastinal or hilar lymphadenopathy, even if you're not suspecting cancer, any mediastinal tumors, or even if you have a lung mass, a primary lung mass that's adjacent to the airways and you can see in biopsy. So it has a very good yield. The needle biopsies that we get with EBUS have a very good yield. They have a high sensitivity, high specificity. I would say probably the one condition for which EBUS is not great is lymphoma, where you can be maybe in the mid to high 80s sensitivity. So you can miss a fair number of these where you get material that is really non-diagnostic. And compared to mediastinoscopy, which was one of those other options available to diagnose lymphadenopathy, EBUS has proven to be equivalent, at least when looking at lung cancer. Now, we know that mediastinoscopy is a minor surgical intervention. It has its risks. It has more risks than EBUS because EBUS is so minimally invasive, essentially. With EBUS, we can get more stations than you can with a mediastinoscopy. But the benefit of a mediastinoscopy is you can get the whole lymph node out as opposed to just sampling it. So, but for lung cancer, it's been proven to be equivalent. So most places consider EBUS as the way to go to stage lung cancer and to diagnose mediastinal lymphadenopathy. This is a little bit more of the same. So that's what EBUS is. And essentially, if I had to convey something to you, is anytime you have lymphadenopathy that you believe needs to be sampled, the way to go is to get the way to go, in my view, would be to do EBUS staging, except for when you suspect lymphoma with especially Hodgkin's lymphoma, which can be hard to diagnose with EBUS. The first case that I showed you, this ended up being sarcoidosis, and this ended up being a recurrence of the non-small cell lung cancer. I'll talk a little bit about this other case. So this was a 71-year-old, 60-pack-year smoker, pretty bad COPD, presenting with cough and hemoptysis, and she had this lesion in the right upper lobe. You can see it on the axial and the coronal images. And you see a lot of emphysema, too. So what would you do for this patient? So she has a mass, she's a smoker, the lesion's fairly big, and she has hemoptysis. So continuous surveillance, sputum cytology, a navigational lung biopsy, or a CT-guided biopsy. So one of these is clearly wrong. So you probably wouldn't do a follow-up in 3 months, or if you do it, you wouldn't tell people you did that. But cytology or any kind of lung biopsy is probably an appropriate way to proceed in this case. I'm going to try to convince you that navigational lung biopsy is the way to go, because it's what I do. There are some reasons why it's particularly useful in this case, and I'll walk you over that. So anytime you think of a lung mass and you think about lung biopsies, you care about what the risk of malignancy is. And traditionally, the rule of thumb is if you have a very low risk of malignancy, so less than 5%, you can possibly observe that lesion and see what happens. If you have a very high probability, then you might even just go in and just take it out, and do an excisional biopsy, and that would be curative in and of itself. And so it's an intermediate probability where most people fall, where really you consider whether doing a biopsy is appropriate or whether doing a PET scan is appropriate, and it's a very broad kind of range of risk. How do you come up with this risk? I use a calculator. This is the one from UpToDate that's been validated for use in assessment of it's for solitary pulmonary nodule, but you can apply it to a mass. And plug in the age, sex, whether it's emphysema, the size, the location, you get a percentage, and that tells you what the risk is. And so that's how you come up with that. So I just kind of wanted to put this up there so that you would have an idea of how we normally approach any type of lung lesion, nodule, or mass. This case was obviously a very high risk. It was like probably 85% probability of malignancy based on the emphysema, the size of the lesion. And so you could argue, well, why not just take it out? Many of these patients have bad emphysema, and so they're not operative candidates, and so that's when a biopsy makes sense. The traditional indication for a lung biopsy would be someone with an intermediate probability where you're not really sure, it may not be worth the trip to the OR, but a confirmatory biopsy is desirable. So what are the sensitivities of all these techniques for diagnosis? So sputum cytology can have it has a range, but it can be as high as 66% when someone has a fairly large central lesion, especially with hemoptysis. So sputum cytology can give you a diagnosis. Usually that's not something I do, but if you have a patient with a mass like this, it would be an appropriate way to start as you're referring them. And it drops off when the lesion is smaller and further away from the airways. Navigational bronchoscopy, I'm going to talk about this in a little bit, but it can have a sensitivity as high as 88%. The pooled sensitivity of navigational bronchoscopy is 70%. It has a lot to do with patient selection. So the lesions that are more amenable to navigational biopsy are the ones that are going to be the most successful. Transthoracic or CT-guided needle biopsies have a sensitivity of 90%. And again, a lot of this is because of patient selection. You're picking patients that you think are going to be easy to get. But it has an overall higher sensitivity, at least from the available published data. CT-guided biopsies have a higher sensitivity than navigational biopsies. And then if you have pleural disease, then cytology or pleural biopsies have their own sensitivities, which I'm not going to talk about now. So what is navigational bronchoscopy? Essentially is a technique that allows you to biopsy the lungs further than you can see. So normally when you look in with a scope, you can see the airway, the main trachea, the main stem bronchi, the first segmental branches, but as you get further away, you can't get any distally with your scope because the scope is a certain size. And so if a lesion is further away, past more bifurcations, then you can see that, but you can potentially use this GPS system to reach that lesion by going through the airways and navigating through the airways with this software. So essentially, you plug in a CT scan into this computer. The patient goes on lies on a board that's got generates a magnetic field, and so that kind of shows you where you are in space, and you're allowed to go left, right, and just follow the directions that the machine gives you to reach the lesion. And once you get to it, biopsy it. There's a couple of different technologies. We have superdimension here, which is, I think, probably the better one. And the key for navigational bronchoscopy, you're going to use it for peripheral lesions, so lesions that you can't see, they're further out. And the larger the lesion and the larger the lesion and whether there's an airway that's leading to it on CT scan are predictors that your biopsy will be successful. So those would be the patients that you would probably choose. Lesions that are at least 2 centimeters and that have an airway leading to them. The pneumothorax rate is probably the worst complication with navigational biopsy. It has a rate as high as 5%. By comparison, usually CT-guided biopsies can have a rate of pneumothorax up to 20%. The pneumothoraces from a CT-guided needle biopsy may be easier to treat because the lung is not edematous and boggy, and you haven't just bronched it. So when you do a NAVI biopsy, the lung is a little beat up from the biopsies, and so it's a little heavier. And so you're more likely to need a chest tube from one of these pneumothoraces than from a pneumo from a CT-guided biopsy. Sometimes IR would just aspirate the air, and that's it. But it is a higher rate with percutaneous needle biopsies. And you can use radial EBUS, which I'm going to show you a picture of, which is a way to ultrasound. Once you get to the lesion, you can put an ultrasound device in it to confirm that you're inside the lesion, and that adds to your diagnostic yield. So this is radial EBUS. It's just a little probe that gives you like a 360 ultrasound. And when you're in the lesion, you're going to see this up here, which is all this. This is essentially a solid lesion around your probe. This is concentric and this is eccentric, so you see the lesion down here. And these are associated with a higher yield. It also helps you confirm that you're really there because all the software is telling you is that you're in the spot where the lesion was on CT scan. The CT is usually not on the same day. If it's the older the CT, the more likely that whatever was there may have resolved, and so you may not be there. Or you may be in the right spot, but the lesion is gone. So having this gives you additional confirmation that you're in the right spot. So compared with CT-guided biopsy, which is so a navigational versus a percutaneous biopsy, the benefit of doing a navigational biopsy is that you have the ability to diagnose the primary lesion and also stage the mediastinum, which a CT-guided biopsy wouldn't allow you to do. You can sample all the lymph nodes with EBUS at the same time in the same procedure, and that gives you diagnosis and staging in one intervention. The overall yield, like I mentioned to you, is about 70%, but it can go up to 88% if you select the lesions that are the most amenable to biopsy, so the ones that are a little larger, that have an airway sign leading to them. In addition, if we normally use a cytologist in the room while we're doing these biopsies, and we get some feedback of what we're getting, and if they tell us that they're not seeing any cancer in the lesion that we get, we can apply this gene test on the airway on airway mucosal cells, and that allows us to figure out what to do down the line. So the problem with these biopsies is that if they're positive for cancer, that's very definitive. But if they're negative, there's always a chance of sampling error, and a false negative result. You just didn't biopsy in the right spot, or you didn't get enough material. So for those types of lesions, when you worry that you may have missed it, having one of these tests helps, the gene classification analysis. I'm going to show you a little bit of that in a few slides. And then I'm going to skip this part. And then lower pneumothorax rate, about 15 to 20% for CT-guided biopsies versus 5. So this is what a bronchosine is. So essentially, this is the lesion that I showed you before, and you see there's an airway going right to it. So this gives you a very high probability of success with a bronchoscopic biopsy. So bronchial genomic classification analysis is something that's been available for a couple of years now. It's not very widely used, I don't think. What this is a test that looks for genetic mutations in the bronchial epithelial cells of the central airway. So essentially, it's a brush in the trachea or the mainstem bronchus. And the theory is that in order for you to develop cancer, you need to have a number of mutations that need to sort of accumulate. And so the early mutations will be present in the entire airway tree. And so by testing for those early mutations, that will give you that can give you a prediction of what the likelihood is that a lesion in your lungs is malignant or not. It's been validated for smokers only, and it works best in lesions in the lungs, so nodules, with an intermediate pretest probability. So people who fall in that intermediate range of 10, 60%, 5, 65%. It has a sensitivity of 88% and a negative predictive value of 91%. So I think this is probably the only role for this type of testing is smokers with lung lesions with an intermediate pretest probability of lung cancer. When that test is negative, that's very reassuring that the lesion may be benign. The way you would use this test is that if your pretest probability is always going to be intermediate because you're picking that patient, but if your post-test probability is very low of lung cancer, then that would favor continued observation, whereas if it's the same or higher, that would favor maybe proceeding with a second biopsy of a different kind. So I'll show you a case for that. So this is a 38-year-old female, never smoker. She was a nurse. She is a nurse. She had what sounded like acute bronchitis, and for some reason, without any risk factor, she got a CT scan. And the CT scan showed a nodule. Yeah. Is that you? And she got herself a PET scan also because she was very insistent. She was very worried about this. So I mean, it doesn't look completely benign. I have to agree. It's somewhat sizable and maybe a little speculated. So it's not the prettiest nodule I've seen, but it is someone with a very low pretest probability, right? And then now she has a PET scan, which sort of changes your pretest probability a little bit because if something's avid, something's active, that is suggestive that it could be malignant. And so the nodule was avid, and then she also had some right hilar adenopathy as well. So she ended up coming to see me, and what could you do for her? So you could do a follow-up in 3 months. You could do a CT-guided biopsy of that nodule. You could do a navigational lung biopsy. You could do endobronchial ultrasound with biopsy of the lymph nodes, or you could do a VATS. So probably follow-up would have been appropriate if you hadn't had so many of the tests that she had. Now that you have an FDG avid lesion and all this excitement and nerves, she ended up having one procedure with a combined navigational biopsy of the nodule and sampling of the lymph nodes. The results were non-caseating granulomatous inflammation, which in this case is probably the result of some sort of histo, I would guess. The cultures were negative, and the lesions disappeared on follow-up. But she did get, because the cytology during the case was negative, we weren't seeing any malignant cells, and you usually don't get granulomas during the case, so you don't get that information. That's something that comes after with the final results. So during the case, you're not seeing cancer, so we did the brushings for the genomic classification analysis testing. And you can see this is the way the report comes back. So she started as an intermediate probability, as most people do. Otherwise, the test isn't, you typically don't run this test if it's not intermediate probability, because for high risk and low risk probabilities, the test is not really that useful. And based on the analysis of all these genetic mutations, she came back as a very low risk of malignancy because she didn't have any of these mutations. So this is a high negative predictive value for malignancy. And sure enough, her lesions disappeared. And all this requires is a little swab, of the airways. So this is one situation in when this is useful. I would say I use this mostly for lung nodules when your rapid cytology is negative and you suspect that you're not going to be sure if it's truly negative if you missed it. This is something that gives you an additional data point to support what you do next. So if this had come back as a high risk, she would have probably gone on to have some sort of biopsy, probably an excisional biopsy. So for the rule of thumb for sampling lung lesions is that if they are peripheral, you can only reach them with either a navigational biopsy or a CT-guided percutaneous, or a VATS if you want to go invasive. And for anything that's central, you can either go with an EBUS, which allows you to use ultrasound to put a needle through the airway, or a mediastinoscopy, which allows you to resect the whole the whole lymph node. And so this is kind of how you approach these two. Okay, I'm going to move on. If you guys have any questions about any of this, I guess we can do that at the end. So this case, he was a 65-year-old never smoker with progressive cough and dyspnea. No real exposures. He had become hypoxic to the point where he needed supplemental oxygen. He had a restrictive defect on PFTs, and he had this ILD on CT scan. So there's scarring in his lungs, and this didn't really follow any pattern that was diagnostic. Sometimes if you have a very clear IPF pattern on CT, you can make a diagnosis with just the clinical and the imaging. This was not one of those cases, and he had some progression. So this would be a person who probably would need some sort of pathology to diagnose this condition, this ILD. And so what can you do? You can do either no biopsy and just treat empirically with corticosteroids. You could do a conventional transbronchial biopsy. This is a biopsy where we just use a little forceps tool, a transbronchial cryobiopsy, or an open lung biopsy. So the gold standard, I have to say, for any type of ILD is a VATS, an open lung biopsy, getting a piece of tissue, and that gives you great understanding of the disease process going on, because you get you can see the entire lung architecture, so you can see what components of the parenchyma are affected, vascular parenchyma, and you can see you need a big section of tissue to really understand the pathology of interstitial lung disease, which is very complex for pathologists to kind of figure out. So I'm going to make a case that if you're going to biopsy, you can either go with a VATS or a transbronchial cryobiopsy, which is sort of what I do and what I'm going to talk about in the next few minutes. So cryobiopsies are done with, it's a little flexible probe that goes through the scope, the working channel of a bronchoscope. And the tip of it, the probe is attached to a tank of CO2, and once you activate the flow of gas through this catheter, the tip of the catheter freezes, and an ice ball forms around it. And when that happens, the surrounding tissue that's in contact with the tip of this catheter gets stuck to it, just much like when you lick a popsicle and your tongue gets stuck to it. So then you pull, and you get a fairly large piece of tissue. These are real-life sections, very large. So you see that you can see you have bronchial wall, you have vessels, and you have alveolated tissue. And so this gives you enough histology, enough size, and a relatively preserved architecture that you can assess the disease process much better than you would be able with like a little bite forceps, where you get like a little section of this, so you can't really see what's going on everywhere. So these biopsies are big. They can be up to 5 millimeters in diameter, and they're much bigger than what you get with a forceps biopsy. And they have been studied and done for a while now. And the indications for this type of biopsy would be any type of diffuse parenchymal process, because you can't really direct where you go with your biopsy. So you typically sample multiple areas of the lung, much like when you do a VATS biopsy, where you sample 3 different lobes, but you're not really going to a specific area. It's not like when you're targeting a tumor where you're kind of wanting to go to that area. This is a process that has to be diffuse, and so any place would be fine, and so you just have to sample multiple areas to see what's going on in the upper lobes versus lower lobes, because that information really tells you one disease process from another, whether it's homogeneous involvement or heterogeneous involvement. So it can be used for any diffuse parenchymal lung disease like ILD, non-resolving pneumonia where you suspect there could be also an ILD. It's been used for lung transplant patients to diagnose acute rejection. And a big one, most of the patients that I got to do these on are patients who for some reason are considered not a good candidate for a surgical lung biopsy. So they feel like they're too sick to have a VATS, and so this is sort of the next best thing. Although I would argue that it may be a good first-line biopsy, not just for people who can't tolerate a surgical biopsy. The major complication of this type of biopsy is pneumothorax. The rate is about 15%, 13 to 15%, and then bleeding during the procedure. The bleeding stops, but it may need to be tamponaded. Sometimes you need to use a bronchial occlusion balloon to kind of block the blood from kind of flooding the whole airway, and it can be pretty scary. But bleeding is not a big problem once you control it. It's mostly the pneumothorax that you have to keep the patient in the hospital as opposed to sending them home. Most of the time, I would say 80 to 90% of the time, this is an ambulatory procedure as opposed to a VATS where you have to have a chest tube and stay in the hospital. Maybe not always, but most of the time. And there's the theoretical concern for exacerbation of ILD, like when with VATS lung biopsies, you always worry about a flare of the underlying ILD from the biopsy. So there's a theoretical concern that any type of biopsy might cause that same problem. That hasn't been seen with cryobiopsies, but it's a concern. On some of the biggest meta-analysis on this type of biopsy, most of them done for diffuse parenchymal lung disease, like interstitial lung disease. The yield is somewhere around 80%, and a pneumothorax rate of about 12 to 15% with moderate severe bleeding in a significant percentage. And many of these studies are difficult to compare because the severity of bleeding is defined differently by different people. Compared to VATS, and the cryobiopsy started in Italy, where this group by Paletti is one of the biggest people doing this type of research and this type of biopsy, and they found that it had a very low mortality, less than VATS, and a yield that they believe is comparable. I'm going to show you some of my own data. This seems a little too good to be true, but they report a diagnostic yield of up to 80%. And a big reason why there's variation in the diagnostic yield is also because it's very dependent upon the pathologist. And most of these diagnoses are done by multidisciplinary consensus, where pulmonologists, radiologists, and pathologists kind of agree on a diagnosis, and that really depends on the experience of everybody involved. So, if the group is willing to call it, IPF, then it's diagnostic. If the group is not willing to call it, then it's non-diagnostic, and that's all there is to it, And two different groups might have a disagreement on the diagnosis because it's a very nuanced type of thing, the diagnosis of ILD. I'm working on this project in a prospective cohort at the University of Cincinnati, and we did 45 patients prospectively, and we had a yield of 72% with a pneumothorax rate of 13%, and significant bleeding in 3 cases out of these. And significant bleeding means patients that had bleeding that required that the procedure be extended for up to a couple of hours, and that we removed bunches of clots. That when your airways get filled with blood, it takes several hours to remove all those clots, which you do also with a cryoprobe. But all of those patients, got extubated and left the hospital in less than a day or two. And the smattering of diagnoses in these cases are all over, so you get all the soup letters that you may be familiar with, but you can diagnose all kinds of different things, from UIP to Langerhans cell histiocytosis to malignancies, eosinophilic pneumonia. You can see all of this. So the diagnostic yield, as a summary, is probably around 70 to 80%, and heavily dependent upon who the pathologist and the multidisciplinary team looking at it is. There's a general feeling that these biopsies are probably less useful for fibrotic types of interstitial lung disease and more useful for the non-fibrotic types. And that's because sometimes in fibrotic ILD, you really need bigger pieces of tissue and multiple sites. By the way we do these biopsies are, it's a total of 5 biopsies. So it's 2 from the upper, 2 from the lower lobe, and 1 from the middle lobe on the right side, and a similar thing on the left, so that you can have all these different areas represented, and you can see if the disease process is heterogeneous, homogeneous, and whatnot. And a pneumothorax rate is about 12 to 13%, and most of them require chest tubes, and those usually stay in the hospital for 2 or 3 days. We don't have enough data to comment on the risk of exacerbations of interstitial lung disease. The meta-analysis from the Italian group shows that their mortality was low, so presumably most of the mortality related to VATS is from flares of the ILD post-biopsy. So it doesn't seem like it's a thing, but it could be. And there's a lot of heterogeneity amongst different groups on the techniques that they use, how many biopsies they do, and how do they control bleeding. So that's a little variable. So this is something that I would like to bring to UC in the next maybe year or so. Okay, what time is it? We have time. is another case. So I'm going to switch gears a little bit and talk a little bit about therapeutic modalities available. I'm going to show you a case that hopefully will exemplify some of what we can do. So this was a 55-year-old woman. She was a never smoker. She had metastatic colon cancer that had been diagnosed previously, and then she had chemo and radiation. But she progressed. Her disease recurred and progressed, and she presented with pretty bad lung and mediastinal disease from her colon cancer, progressive dyspnea. She came in very symptomatic with labored breathing, and this was her imaging. And you can see that there's a lot of disease in the center of the chest. Is this mass, which is the pulmonary metastasis, and then you can see that this is the right and left main stem, and in the left main stem there's this big chunky lesion there that's kind of occupying most of the lumen of the left main stem bronchus, and you can see how the right, once you get past this area, it kind of narrows very, very markedly. And so she had pretty severe central airway obstruction from malignancy. This was her bronchoscopy. So this is a rigid, is it playing? Yeah, it's a rigid bronchoscope. And most of the time you use rigid bronchoscopy when you need to deal with this type of problem, a central airway obstruction that's causing significant symptoms and at risk for respiratory failure and massive hemoptysis. And so this type of bronchoscopy, which uses a rigid barrel, allows you to control bleeding, allows you to use bigger tools to remove tumors. And I'll show you what we did in this case. So essentially the barrel goes in, and you can go into the left and right, but you can already see down there that there's tumor on both main stem bronchi. So just getting some light again there. And you can see how it was almost completely occlusive on the left, and she had some lesion on the right as well. So then, so here we're using a laser. So this is one of the hot therapies that I mentioned earlier. So what this does is it cuts and cauterizes tumor. So this would prevent it from bleeding as you core it out, and allows you to cut it out essentially without creating a lot of bleeding. So this is deceiving. It looks as if it's very superficial, but it has about a 1 centimeter depth of penetration. So you can treat the tumor and then excise it with minimal bleeding. So in this case, we're choosing to treat the left side because it was the one that seemed the most involved, and also the left side didn't seem to have any distal disease as opposed to the right, where it was kind of diffuse all the way down disease. So in addition to laser, which is a kind of very pinpoint, kind of very deep type of therapy, there's a different kind of heat therapy or cautery therapy, which is called argon plasma coagulation. That one is more superficial. It's not as directable as this one, which is kind of like a little pen where you can direct it exactly how you want it, and you can also adjust the power of the laser to improve the depth of penetration. So now this requires that your FiO2 during this time be below 40%, ideally below 30%, so that you don't ignite an airway fire. So then this is what we just did. So then after we cauterize the tumor, then you can advance the barrel and just kind of core it out. So you just push it in, and it kind of gets in your barrel, and so you can grab it and take it out. And so there's a bunch of different tools that you can use through a rigid bronchoscope that you can't use through a flexible bronchoscope. So you'll see putting in a grasper. It's a little embarrassing because that's the wrong grasper. And I don't realize it until a little later, so it comes out. And then that's probably the right one. Yeah. So then the tumor comes out. And there's some more to this. And then you can see that the distal left is now open, and you can see the upper and lower lobe down there. I mean the upper and lower, left side lobes more open after that tumor was removed. And then right here we're deploying a stent in place. So after all this tumor was removed, she still had pretty bad compression of the airway, and so to stabilize that, we're putting in a stent. It's a silicone Y stent that will sort of sit there and just kind of keep the airway open. And these are palliative interventions, so this is something that we would hope would stay there until additional therapy is delivered that allows the lesions to shrink or the patient dies. It's meant to improve shortness of breath, improve quality of life. So the stent is deployed on one side, and then you pull it back, and it kind of sits over top of the airway. And then you have to adjust a little bit. And then I'll show you what it looked like after. So this is bronch after the stent was finally put in. See how the left side is pretty open. There's a little scar where the tumor was. And on the right side, she still has some residual disease that we knew was there, and were not really taken out. But she had symptomatic relief from this. And again, this is a palliative intervention. So the goal is to buy some time, maybe buy time until they can get additional therapies if they're candidates for that. These stents are removable. Most of the stents we put in are removable. So you could potentially take them out once they're no longer needed, especially if someone has a transient need for it. If the obstruction is something that you expect might resolve with treatment with either chemotherapy or radiation. And this is the post X-ray where you see the stent in place. So endobronchial metastases are not very common, but they're the most rewarding to treat because typically they just are in one spot. Once you get rid of them, the rest of the airways are intact, as opposed to a lung that's entirely kind of consumed by disease. It's kind of spreading into the airways. So they're the ones that have the best results with therapeutic bronch, like this case. And this is just a little bit about malignant central airway obstruction and how it can be inside, it can be pushing from the outside, it can be a mixture of both. Most of the time it's a mixture of both. Depending on what the appearance is, if it's mostly extrinsic, you'll probably put in a stent. If it's mostly intrinsic, you'll try to remove it with laser like I showed you just now. And then when it's a mixture of things, you'll probably do both, like we did with this case. There is no clear survival benefit with what's called multimodality bronchoscopy, just going in and just kind of removing everything you can, and then if a stent is needed, putting a stent in. It's mostly meant to improve quality of life and improve symptoms. Sometimes you can get patients extubated. If they're intubated for a lesion, you can successfully extubate them, liberate them from mechanical ventilation by doing this type of thing. There's some literature that suggests that there may be a trend towards improved survival, but that's not really been proven. What has been proven is that in this very large registry of therapeutic bronchoscopy for this type of problem, is that there is an improvement. So we're usually successful in opening up the lumen and restoring the patency of the lumen to over 50% of normal, which is what would be desirable. And we know that quality of life improves. And so in this very large registry of most centers that do interventional pulmonology in the US, the outcome of achieving patency of the airway, so reopening the airway, was achieved in most cases, so 93%, but only half of them had improvement in dyspnea and quality of life. And so the key to this is not necessarily how big the blockage is, but how symptomatic they are from it. And the patients that had the most symptoms from it, so severe and symptomatic, those are the patients that mostly benefited. So just because something is severe, if someone doesn't have symptoms, they probably don't need to have something done. It's the ones that are really dyspneic that benefit the most. And then the complication rate, this is a self-report type thing, so I wouldn't trust this, but about 4%. And these things can have big complications. So you can knock out a vocal cord, you can lacerate an airway. And most of those things would be devastating and essentially a death sentence if you create a big laceration in an airway, because those patients are not surgical candidates. No one's going to go in, to repair, a tear or something. So luckily, it doesn't happen very often. So I'm going to talk a little bit about bronchial thermoplasty, since this is something that we hope to begin providing here very soon. We have the equipment, and we have, I think, the privileges, and so it's almost ready to go. So what bronchial thermoplasty is a procedure done endoscopically through a flexible bronchoscope, and you use a little catheter that has a basket that opens and closes like this. And the point of it opening is that it can touch all the 4 quadrants of the airway. And what this does is it delivers radio frequency, thermal energy through radio frequency. So it heats up the airway to 65 degrees for 10 seconds each time you activate it. And what it does is this heat therapy essentially leads to a number of changes in the airway architecture that essentially reduce the amount of airway smooth muscle. So it decreases that, which is usually hypertrophied in asthma. And it also seems to get rid of some of the neuroendocrine cells that are in the airways that might mediate some of these, some remodeling and asthma symptoms. And it also gets rid of some of the bronchial nerve endings that might also be promoting bronchoconstriction. So it does a number of things, but we're only treating, the way this procedure is done is it's done through a bronchoscope, but you go down with that catheter and you treat the airways as far as you can see, which isn't very far. So you're treating more of the proximal airway. So we're not really treating the tiny, small airways, but we're getting, in the airways that we're treating, we're reducing the amount of smooth muscle and causing some of these, loss of neuroendocrine cells and nerve endings, which we believe may be helping to improve asthma symptoms. Now, the bottom line is we don't really know how this works. But it seems to work by doing some of these things, by changing the architecture of the airways. Bronchial thermoplasty has been proven in clinical trials to decrease the rate of severe asthma exacerbations and probably improve asthma-related quality of life. And the benefits seem to be lasting. They seem to remain at 5 years follow-up. And it's a procedure that's relatively safe. So the only real complication of bronchial thermoplasty is having an asthma exacerbation peri-procedure. So because you're messing with the airways and you're irritating them by putting in a catheter, there's a good chance that you might have an asthma flare immediately after. People who get past that immediate post-procedure time don't seem to have any other big problems. There was concern that because you're burning the airways, you'd have airway stenosis down the line, but none of that's been proven to happen. So it's relatively safe. The question is, how effective is it? There appears to be a definite improvement in outcomes, particularly severe asthma exacerbations, days missed from work, emergency room visits, that type of thing. And so this is a picture that shows one of the things that bronchial thermoplasty does, which is reducing the amount of airway smooth muscle. And this is a before and after, and you see all this smooth muscle that's gone. This is extreme, but it's pretty. So presumably less smooth muscle, less bronchoconstriction. One of the drivers of asthma, is treated. So who would be a candidate for this type of therapy? Typically people who are all the way over here, so step 5 or 6. So when your therapies, you're on max doses of, this is not meant for you guys to read, it's just to look at this little ladder and how you're falling off on the right. That's usually where you go to thermoplasty. So, when you've treated asthma optimally with high doses of inhaled corticosteroids and you do everything as you're supposed to be doing, and you get to this point where you're still not controlled on optimal therapy, then those patients would probably be evaluated to see if they would be eligible for some of the newer biologic therapy that's available, the anti-IgE, omalizumab, or anti-IL-5, like mepolizumab, so the newer biologic therapy that's available for those types of patients. There's some patients that will be eligible for that and will not respond or continue to have pretty severe symptoms in spite of that. And then some patients that won't be eligible for those because they don't have any of the markers that you're supposed to have to be eligible for those. And so those are the patients, so with severe persistent asthma that are at that stage where there's nothing else available, those are the patients that we typically consider for thermoplasty. Now, most of the studies that have looked at thermoplasty because they were worried about severe consequences of the therapy they selected the healthier asthma people, even though they were severe persistent. They were healthier, meaning they didn't have very low FEV1, and so that is something that would be considered on a case-by-case basis if someone has very severe obstructive lung disease, whether this should be done or not. Personally, I have done most of the thermoplasties that I have done have been in people with pretty bad obstructive lung disease, because those are the patients that usually get referred for this type of therapy. But if you look at the strict, eligibility criteria, you're supposed to have an FEV1 of over 60%, and there's a number of other things that, most of the very severe people were excluded from these trials. Arguably, maybe the people who would have the most benefit. So that's about thermoplasty, and so we are ready to go with this. So hopefully we'll have our first cases in the next year. I wanted to mention this is something that is also new to PPMC. We did one case of this, photodynamic therapy. Unlike the laser that I showed you earlier, this is something that works slowly. This is a different kind of laser that just delivers a light. And what this does, it's also for lesions in the airways like that metastasis patient. But the way this is done is a drug is given to the patient that is photosensitive. The drug is activated by light. And it concentrates in tumor cells. So it's an injection. The drug's called Photofrin. And in 48 hours, it's supposed to only be persistent in tumor tissue. So it washes off of everything else, and it stays in the tumor. So then you shine a light with a bronchoscope, and that induces apoptosis and necrosis of the tumor tissue. Why would you do this as opposed to a more aggressive, multimodality bronch like the video I showed you earlier? This would be more for patients who either couldn't tolerate a very low FiO2, so they couldn't, they need a lot of oxygen, and you really couldn't get that FiO2 down where you could use laser safely, or lesions that are in the upper lobes or very distally where it's not easy or convenient to get them out, or stuff that kind of branches out and it's kind of diffuse involvement. So this light allows you to shine, to essentially induce tumor necrosis by shining this light. Usually it involves doing a treatment session where you shine the light for a delivery of 200 joules, and then a second bronchoscopy 2 days later where you go in and you just kind of remove all the dead tissue. This can also be used for carcinoma in situ of the airways if you have that. It can also be used for that indication. And the problems with it is that the drug hangs around your body. Even though it concentrates in tumor tissue, it hangs around your body for up to a month or so. And during that time, you have to be away from UV light. So you can't be exposed to sunlight or strong indoor lights. And so patients have to wear, sunglasses, caps, gloves. And they do this little test at the end of the period where they shine a light through a hole in a bag, and if they get a reaction like this, it means that they're not ready to go back in the sun. So it's a little cumbersome because of that reason, and there's a little bit of timing involved. We have to time an outpatient injection and bring them in for a bronchoscopy, but I think it's a very useful technique in people who can't tolerate anything more invasive with some good results. So that's available, and we hope to do more of these cases here soon. So I think that's all I have to say, and I am on time. So if you have any questions, I'll be happy to answer. Yeah.
So clearly, first of all, kudos from palliative care. The ability to choose which metastasis filter,
Yeah.
really important.
Yeah.
And that looks really great. I have a different question. And it is, clearly over-collection of information becomes more hazardous to patients as we can do more,
Mm-hmm.
right? So it's great that you have all those scans from that young person, but of course she never needed a CT. And
Yeah.
without one, she would have cruised happily into her life.
Yeah.
So we have to leave the cat in the box sometimes, right? And our therapeutic obligation
Mm-hmm.
is not to collect information. Are we going to get to a place where over-collection of information is a sentinel event?
That's a good question. Yeah,
That collection of
Yeah.
The overcollection of information was an act that caused harm. So how do we deal with reporting that or avoiding it or whatever?
That's a good question to which I don't have an answer.
I think it's an important question. I think
Yeah.
it applies to IP. He got her afterwards, so he didn't order those. That's kind of a
No. And it's always
societal
somebody way
benefit.
upstream who did it, and that person doesn't get to suffer with
Yeah.
everybody else through tumor.
Yeah. Well, oftentimes people in the medical profession are even harder to deal with this type of thing because they sometimes insist on getting stuff that may not be
The idea
necessary.
that information is bad is anathema to
Yeah.
an internist, right? And
Go ahead.
But the same case, actually, and glad that you helped her get her answers. But as primary care, could you tell us a little bit more about that case? Where did things kind of jump off the cliff, and what could a primary care person have done to kind of help her understand? I mean, the skin. I'm thinking with dystoplasmosis, skin testing, and all that kind of thing. Thinking through the differential diagnosis before she needed to go to you. And
Yeah.
I'm amazed by the technology, by the way. It's great.
Yeah, I think in someone with an acute cough, they probably wouldn't need to have a CT scan necessarily. If it's a cough that's lasting less than 4 weeks, 8 weeks, you can probably just kind of wait and see, be more conservative. She didn't have any risk factors for malignancy. She never really had an X-ray.
That's what I was wondering.
Which was interesting because you may have been able to see something on an X-ray, and that may have prompted a CT. I think having the initial CT, maybe I would have followed her, maybe with a repeat scan in however long, maybe 6 months, maybe 12 months, something like that. Having done a PET scan and seeing it be hypermetabolic just kind of changed the game a little bit, where everybody was freaked out, and so, and her pretest probability really changed a little bit by then because now you have something that's FDG avid, so that pre-test probability, post-test probability game is, it really matters on how you play it. But yeah, I would have probably stopped at the CT and say, hey, follow up in X number of days, or get an X-ray, see if it correlates, and then follow the X-ray, something like that.
I think we have time for one more IP question. Go ahead.
Quick one. You mentioned the Brook University or Brock University risk calculator. Could you tell us a little about that and who's appropriate to use it? I mean, not in primary care, I assume, but
It's validated for solitary lung nodules. So yeah, it's appropriate for anybody. It's not like a specialist test. Anybody you see with a solitary lung lesion would be appropriate for this type of test. And what it gives you is a pretest probability. What is the likelihood this patient has cancer, essentially? And so,
how has it been validated?
large population. I think this is published in the New England Journal, and I haven't really read the details of that, but it's been looked at, essentially the large population of nodules, looking at their outcomes and what they end up having. And so that's kind of how, and there's a number of different ones. So there's some, this one, for example, looks at emphysema, but it doesn't consider smoking history. It's sort of implied that emphysema would mean smoking history, but there's others that give you similar information. And it's a very, the intermediate category is very wide. It's 5 to 65%. So it's the very high are pretty obviously cancers. The very low are pretty obviously not cancer. So there's those in the middle. If you can tease out who is very low, that person might just be follow-up, reassurance. And someone who's very high, you would maybe be more aggressive on. And when you're in the middle, you might do additional testing, biopsies, PET scans, things like that.
Great.
All right. Thank you. Hey, sorry I'm a little dopey.
Post call and everything.